Hypernatremia is primarily just the opposite of what we were just talking about. So now with hypernatremia, this is an opposite picture of the one we depicted earlier. So let me switch my camera and we will. So we're going to have two containers here, again, with the same amount of sodium as before. So I'm drawing in here 8 little sodium molecules. You understand it's just representative. And the fluid is what's going to be different between the two containers. Now, remember earlier we talked about normo or euvolemia. U meaning good volume. Okay? So this is going to be normal again. We start over here with normal, and we've got this much fluid in our container, and this is normal volemia. In this container, we have, actually, I'm going to draw this a little bit differently, just so it'll be a greater differentiation here. All right, so we put that much volume in there. We're considering that normal volemia, euvolemia. In this container, we have less volume. Notice the sodiums are the same, but there is this much difference in fluid. So this is hypernatremia. Running out of room. So this is hypernatremia. And in this case, the patient is hypovolemic. Notice here, the fluid volume is decreased, hypo. The sodium, while it is the same amount of sodium, when you sample it, when you take this out, there's more sodium in proportion to the fluid that's in this container. So it's hypovolemic and it's hyperosmotic. They're more concentrated. There's less fluid. It has a higher, an increased osmolarity. Right? All right. So in this case, now we see what happens when volume is decreased. That's what's here in the middle. So we have decreased extracellular fluid volume. The osmotic receptors send the signal to the posterior pituitary, and the posterior pituitary hypothalamus then secretes antidiuretic hormone. Now we want antidiuretic hormone. So now we want to not pee. In that case, we're going to retain fluid as we ingest fluid, where our fluid levels will go up. We're not peeing it out. Perfect. We're resolving the issue, returning things to homeostasis. Then the stretch receptors are going to notice that there's less blood pressure. So in that case, in order to maintain a sufficient blood pressure to the kidney, remember that's the key, even though the fluid's going around, we've got to keep a good blood pressure to the kidneys so the kidneys know what to do. So in order to maintain a good blood pressure to the kidneys and not create too much urine output, we're going to have a decreased blood pressure, but the stretch receptors are going to accommodate to maintain enough pressure to perfuse the vital organs, brain, heart, lungs. So what happens in the kidney with hypernatremia and decreased volume is a decrease in the glomerular filtration rate. This is the essence of kidney function is the GFR, the glomerular filtration rate. So if there's less blood flowing through the kidneys, then we're going to have a lower glomerular filtration rate. Think about a paddle wheel like at a mill, like here at War Eagle Mill. If there's less water running through War Eagle Creek over there, that paddle wheel's not going to turn. When that creek is running full, then the big mill wheel is going to really be turning. That's an image of glomerular filtration rate. When we have decreased fluid volume, then we're going to activate the renin-aldosterone-angiotensin pathway, which is going to produce vasoconstriction and sodium retention to then cause an increase in circulating fluid volume. If sodium is retained, water follows sodium. If sodium is retained, water is going to be retained. We're going to have an increase in antidiuretic hormone, as we've also mentioned. This is going to cause, as I've already said, retaining the volume, which is ultimately going to retain and normalize the sodium. The key issue here is cellular dehydration. When we are hypernatremic, that means the intracellular spaces are constricted and tightened up around all of this sodium. Think about the picture that I just drew for you. And instead of it being a container, the container is the cell. So that space is going to be constricted around the sodium. Again, as I've said before, treat the cause, manage the symptoms. So with hypernatremia, we are going to replace fluids. In this situation, we're going to replace fluid, not sodium. So we're not going to give these patients sodium chloride infusions. We don't want a hypertonic or necessarily an isotonic solution. This is a great place where we will use D5W. What the patients need is free water. So this is a great application for D5W. It's not going to be the ongoing treatment, maybe a bag or two, until we see things start to normalize, and then we will normalize our treatment. There are a couple of conditions that produce hypernatremia. There are two types of diabetes insipidus. So diabetes insipidus has nothing to do with diabetes mellitus. Completely different conditions and mechanisms, so please don't confuse the two. Diabetes insipidus is a condition in which the brain, for a couple of reasons, signals increased urine output. These patients are going to have tons and tons of urine output, 2 or 3 liters an hour. And it's because of the signal that's coming from the brain basically shut down antidiuretic hormone or not respond. So there are two types. If the cause is in the brain, then the body is not producing ADH or AVP, arginine vasopressin. It's not making it. So if the hypothalamus is not producing or signaling the excretion of ADH, now we've got a problem. The brain etiology is often caused from some type of traumatic brain injury. When I say that, I'm using it in the broadest sense. It can be a concussion from an accident. It could be a stroke. It could be an intracranial hemorrhage. There are a variety of conditions. It could be a tumor. There are a variety of conditions that can cause the brain to cause an issue with the hypothalamus and then not produce antidiuretic hormone. Diabetes insipidus from the kidney is an issue where the kidneys are not responding to antidiuretic hormone. And the cause for this is up in the air. There's a variety of issues that can produce this. If you have some kind of, for example, injury to the kidney or some kind of genetic condition where the kidney no longer responds to antidiuretic hormone, or even kidney neoplasm, those kind of conditions can produce the antidiabetes insipidus from the kidney. There is a simple test that you do to test this, and you You give the patient a dose of arginine vasopressin and monitor their response. If there's no change in antidiuretic hormone, then, if there's no change in kidney output, then what you know then is the kidneys are not responding because you've put it into the system. If, however, you put it into the system and the kidneys then stop this profuse urine output, now you know it's a neurologically mediated condition. In this case, we're going to replace IV fluids very, very, very slowly. That's why I have this here. If we replace fluids quickly, give them too much free water too quickly, remember the cell is dehydrated. I mentioned that in the previous, or right up here at the top. Cellular dehydration is the big issue. That cell is like a really, really dry sponge. So if we put free water into the vascular space, it's going to quickly move from the vascular space into the cell, so much so that it could potentially cause the cells to rupture. Now remember that the brain prioritizes itself. One of the things the brain does is produces concentrating elements that help it to maintain a moderate cellular volume. So it prevents it from getting too dehydrated so that we lose brain function and brain cells die by collapsing on themselves. The issue is those ions, these brain-specific ions, do not diffuse across the cell membrane on purpose. They do this to maintain that intracellular cellular volume. If they move across the membrane, they lose their efficiency. So if we start replacing fluids right away, remember those brain cells are like super ultra absorbent sponges. So they're going to absorb fluid the fastest and first. So they're going to rapidly take up that fluid, and now we can really cause some cerebral edema, some cell rupture and cell death in the brain, and we can really produce brain damage, ultimately brain death if we're not careful. So we have to be very, very careful to replace the fluid slowly and lower the sodium gradually. We don't want to do this too quickly, very critical. All right, that concludes sodium. Next, we're going to start with potassium.